the definition of what the definition is right now is that these are guys that have not fully recovered from COVID, weeks or even months after experiencing the first symptoms. So again, very small sampling of the ones that I'm talking about, just because we've just started looking at them. Some of them it was noticeable at the beginning, and some of them deteriorated into where they are now. They never got their energy back to rebuild. And so there's some kind of symptoms for weeks or months, and they can get better and then relapse from those that are studying this right now. So there's just no one way to look at it, which is why I think it would be very valuable for you to have discussion with your area nursing homes to see if they have recognized any of this, and then what they're seeing that may help you set up programs or suggest services your hospital has that might be able to help them. And the other thing that's sort of interesting is when I went back and looked at syndromes for the last 80 years, there's always been a post-syndrome caveat to the discussion. In the current list, most of those with the long hauler designation are women, and it is causing issues with nervous, immune, and metabolic systems. So common symptoms doesn't mean people won't have other ones, but fatigue, headaches, dizziness, short of breath, pain, depression, anxiety, which I talked about, memory loss or reduction in attention ability. The increased risk is for dysfunction of obviously key elements of life when you talk about heart, lungs, kidneys, and skin, which I'm not sure what all the skin is yet. We're still studying that one. Stroke, dementia, muscle and nerve damage, and some other disorders. So there, again, it is a wide variety. It doesn't seem to be there is a group of one type yet, though we may see that evolve. The opportunity for skilled nursing, why I'm suggesting this is something you should be working with your area nursing homes. And again, this can be a wider area than just the 2, 3, 4 that you may have in town or in your county. This can spread out to counties beyond you if you want to have those discussions. But there were over 713,000 confirmed cases of COVID in nursing homes, and that was as of October 17th, the middle of the month, which means there's a good percentage that are probably going to have the long hauler after effects. There are people that are not able to return to SNF or assisted living or to home because of the long haul effects that have immediately appeared after the stays in hospitals and or in skilled, meaning swing beds and so forth. So Mayo Clinic has started doing some studies, and they feel like most of these effects are obvious for more than a year, and they're still ongoing, obviously, with that testing. There is some work being done in palliative and hospice organizations where they're trying to get Medicaid coverage. They're working with the administration for legislation to get Medicaid coverage for the palliative care in particular that may have pain issues, ongoing ability to eat and function. And the ideas behind this is that they're involved in this, then there's potential for fewer hospitalizations, which is also important for Medicaid, Medicare. The best practices would, again, working with your long-term care facilities, your skilled facilities, and trying to address at-risk populations, what they've noticed, what the vaccine rates are going on, and then any side effects post the hospital stay if they had a hospital stay. For your role in this, a lot of this is for you to provide the education. And I think ultimately that education is going to be ongoing. We're not seeing the end of COVID. You know, there are hot spots. I mean, Canada has a hot spot now, and they've been relatively quiet through this whole thing. So it's going to come and go. And as the variants come and go, I wasn't around in the, at least at working in this field when we started really studying flu and realized why we had to go to a flu vaccine every year. I assume this is going to be a similar outcome. But we need to be looking at, when we're educating our population, educating our nursing homes, working with our physicians, that older adults are going to be more impacted by this, and anyone with any underlying chronic conditions is going to have problems. There are higher mortality rates, obviously, in long-term care and SNF because of the age of those who reside in long-term care and SNF. And we're beginning to see some ethnic and racial disparities. I will add that there's some studies going on, but I think we're going to see some disparities in rural health versus urban health also. Just not enough factual information on that yet. I would begin, if you have nurse navigators, that's a place to begin. Social workers, care management, where you are helping the nursing homes as patients are coming back from the hospital, particularly those who have had COVID in the past and they're back in the hospitals, or this is their first round with COVID. And then the second thing I think that's important for you to be discussing, again, with your social workers, care management, nurse navigators, there's going to be a lot of social isolation factors. I would say the group that's not fitting into this neatly right now are those who are going home, who are not residing in assisted living or a long-term care facility, who have families that are trying to take care of them. And we may see more social isolation factors from that group. And if you've done any research on that, when we have the social isolation, we tend to have more ED and hospitalizations from that group for lots of good reasons and lots of reasons that you can presume. There are some people that are doing some specific cases. I'm getting some background noise. Do you hear that? I don't know that everybody's muted. We'll try again.
Yeah, we lost it again, Kerry. Not sure where it's coming from.
So to tell you how old I am, about 110 is what I feel this week, but to tell you how old I am, I did, one of the courses I had to take when I was in college was a radio course. And what they do is they put a broadcast, a different news broadcast into your earphones and make you read another one. And it is an amazing process because you can't do it at first. Your brain can't comprehend it. So I feel like I've gone back to college again, trying to listen to other things and keep talking. So St. Barnabas, which is a New Jersey hospital system, has started what they call CARE, which is Comprehensive Assessment, Recovery, and Evaluation for those who are the long haulers. And in 7 months, they have treated 120 patients. So they got on top of this pretty quickly. And this is one of several hospitals that I could find where they were working on it. They do, each patient obviously gets an individualized care plan, but they're specifically looking at health issues and quality of life factors. So it's health and how's this impacting their life and what are the limitations. So I'll go back to the case study that I'm working on right now, the lady that was very active in a nursing home, who's now sitting in a chair in the dark in a room alone and doesn't want to eat, doesn't want to come out and socialize at all. So quality of life factors there are what we're trying to work on, as well as can we do anything about the underpinning of this? So they involve in their care program physicians and services from 17 specialties. And you will see right on the front end, we're going to have behavioral health and psychology probably in all of these programs as we're trying to address these patients. Cardiology, dentistry, dermatology, infectious diseases, pulmonology, neurology, radiology, and respiratory therapy. That is a pretty comprehensive program. So they started out addressing what was going on in their community. They decided they needed this broad range of experts. They also wanted a broad level of care options. For instance, you saw respiratory therapy on there. That may only impact 20% of those that they're treating for long haul. But they needed to know that they were on the team. They are using nurse navigators to identify patients and then to follow patients. And what they are doing also is with the swingbed and skilled patients, they're following them for 30 days post-hospital with a nurse navigator to see if it is developing later, not just immediately after a hospital stay. And then once somebody is identified as a long hauler, they're individualizing that and planning specifics for that patient. So they are also working with their area nursing homes with a multidisciplinary approach, trying to help them determine care plans, figuring out who's there and what services are going to be needed, and then obviously working with outpatient and home health options too. There are two levels of care that I think will be dealing with long haulers for the next couple of years. And one is the LTAC setting, which is they have always done in our industry, and for the last, 20 or 30 years, they've taken the chronically ill, and we've actually honestly done most of our vents. Even though skilled nursing has always had the capability of taking vent patients, very few, in fact, I think I've only worked with 3 in the last 30 years that their whole service was vents at a skilled level. So trachs, vents, hemodialysis, the sicker patients may and probably still could go to an LTAC. So the question comes for you with your swing bed program. One, they've obviously got to meet skilled criteria, which isn't going to be too hard, I think, with the long haulers for the most part, because a lot of what they're dealing with are respiratory diagnoses. That I-6200 and I-6300 are categories on the MDS. They're disease processes that are in Section I of the MDS that I've suggested before. You probably should look at that list, because those are approved types of admissions to a skilled program that CMS has laid out. But we may have people that obviously COPD is an issue, respiratory failure is an issue, and I just picked on respiratory diseases here. There are others. There are some proposals already to add a category to the MDS for long haulers. That's how serious people are expecting it to be across the country. Whether that happens or not, if this had come up 2 years ago, it probably could have happened because they were changing the MDS at that point. They're now, and it was delayed, as you know, I think you may know, from 2 years ago now, October, and it will still be delayed another year before the new one is put in place. So I don't know if they have time, the ability to change it, but that should again go to the seriousness of it. So I'm drawing this to your attention because I think you have a choice here where you actually can contact and work closely with your nursing homes, with area nursing homes, with home health, with outpatient services, all the services to say, how are we identifying this in our community, and then figuring out what your role might be in that. And then secondarily, I do believe, because as I've suggested, I think the swing beds are going to take more clinically complex patients. So those long haulers that have had serious damage that has led to lung disease, renal failure, other issues that are coming up, those might be patients that can stay with you longer. And so one of the things before I get into the next slide really will be the fact that in swing beds, our length of stay has been around 2 weeks for primarily rehab patients, and around 3 weeks for medically complex patients. We've seen it spread out towards 30 plus days, a lot of times because of IV antibiotics, for instance, being treated where the nursing homes couldn't take care of it, whatever. It may have been the type of antibiotics, it may have been piggyvax, whatever they couldn't do. So we've started to see a spread out into that. We do have COVID patients that have been in swing bed programs 3, 4, 5, and even up to 6 months at this point. So this is, when we're talking about long haulers, we're not talking about the initial COVID diagnosis. We're talking about the post-COVID diagnosis. However, we've now seen patients in skilled go out further. So there are some basic rules I want to remind you of. One is they've got to meet skilled criteria, that they need to be ahead in the bed because of nursing services. Primarily, all these patients are going to need rehab just to keep function. Laying in a bed doesn't do much good for people that are sick and older. So there will be some need there. So they have to meet the skill criteria. The skill criteria for you then means you may be adjusting your admissions criteria to fit certain types of patients that you're seeing in your area that need to stay longer. How we're going to justify it is, in theory, anybody in Medicare A has 100 days. In reality, Medicare has not been very happy for the last decade for us keeping people for 100 days. I think tube feeders are probably the best example, that we're trying to figure out when the need for them to be in skilled and when they are going to be a tube feeder for life can go home, and where's that breaking point. So I would suggest this is going to depend very heavily on your documentation for what these individuals need. It's very easy when I talk about some of the nursing home residents, patients that I saw, residents that I've seen and been talking about for the last couple of weeks, that they may need short stays. That may not change your length of stay that much. They may need medication adjustments. They may need a team of different types of physicians and services to be able to look at them, to adjust the services for them. So that is something that you can work on. And again, the long haulers for right now would be within 30 days of discharge from acute, because even though we're not following the 3-day rule at this point, we are still necessarily, I think to be safe, would be tying this to their COVID stay or an acute stay because of long hauler or a post-COVID issue. I think that's just safer for your documentation. And then the length of stay is really going to depend on documentation, just straight out. What's the severity of it, and what's the signs and symptoms that you're working on, and meaning that it is active, it requires your skilled level of care, skilled nursing, skilled therapy, and other services in the hospital. We need to have documented when the infection was noticed, what the results were, anything that they have from their hospital stay, which could include lab tests of all sorts of kinds, respiratory, particularly if we had any patient positioning during their COVID stay, any devices that have been in place since COVID began, medications that are now involved, treating either the complications and things like fatigue, and I would add anxiety, depression, because that seems to be showing up in many of the patients. The need for PTOT and speech. There will probably be more need for speech with this population because of swallowing difficulties, lack of eating, interest in eating, and so forth. Physician visits, so this will probably cement our telemedicine consults by specialists. And the bottom line for all of you on the phone is we're going to have to show the 24-hour nursing documentation, the need for the patient to be ahead in the bed and not getting home health or not home with family. So anything that you can specifically relate to the severity of whatever's going on in this time period for that patient, whether we are adjusting meds, whether we're having to do oxygen therapy, whether, I can't even think of a full list there, but everything that's listed there would be something that could qualify somebody for a skilled stay. So a lot of this now, yes.
Kerry, I was going to say there was a kind of a comment that the question was asked before you really got into your discussion, but it says, we have only had patients in swing beds to 20 days in their hospital. Can we keep longer? Which you've addressed that. I don't know if there's anything additional you'd like to say about that. And we have been sending them to the facility for longer term, but it sounds like you're encouraging to keep them in the swing beds as long as possible. So I wanted to make sure you realize that comment was in chat.
Oh, yeah, I haven't seen it. So there's two answers there. Let me do the second part first, which is if they can go to a skilled facility, long-term care facility, you're going to follow the same pattern that you have worked with your area facilities. The issue is the complexity of some of these patients and or equipment needs for some of these patients your area nursing homes may not be able to take. Certainly if it's a return of resident, you want to have conversations because getting them back to their home, which happens to be in the nursing home, has a high priority. So I think this is the first step is where I started, that you need to be having some conversations with assisted living, with nursing homes in your area, with your SNFs in the area, and maybe multi-counties around you, just to determine what is going on, because I think we're just on the front edge of that. The second thing is the 20-day has always been an arbitrary number. You have had the ability all along to keep up to 100 days like the nursing home. you under skilled nursing home rules, regulations. The issue is, one, do they need skilled level of care, which we've discussed? And secondly, you've got to remember that you are primarily an acute facility that happens to be using swing beds. So there have to be beds available for acute patients. So I think we're hitting flu season in Florida already. So the need for beds for those who have flu or other things going on is the second part of it. The arbitrariness of it, I think, comes to a choice that's been made by a lot of swing bed programs, not right or wrong, just a choice that was made, that on day 21 is when the copays kick in for traditional Medicare. Copays kick in at different times for the Medicare Advantage programs and certainly for all the insurance products. So that would be your billers, your revenue departments that would have to let you know when that's happening. But that was so that they didn't have to get into copays. There have been plenty of programs that they've been taking 30-day IV antibiotic type of patients for a while, and they've made their decisions internally about how to address that copay. I will tell you, you must bill it. You can't not bill it. So just know that firsthand. That's breaking federal rules. So you have to bill it. The question is it being collected, and are you making enough revenue in other ways to cover that? So that's a financial decision that's often made, and that's for your financial people and your C-suite to decide the advantage of going over 20 days or not. And I think the two main indicators will be, what you're going to do about copays and collecting them, and then two, the availability of acute beds. If you're taking a lot of acute patients now, do you really want to fill, 10 beds versus 5 beds with swing bed patients that may not be discharged for 30 or 40 days? And I would say 30 is probably going to be the range, the max range. Does that help, Becky?
Yes, it does. I did have a question emailed to me. What type of readmission rates is Kerry seeing for swing beds across the country? I don't know if you collect that information, Kerry, or not.
Well, I haven't seen anything formally. We're beginning to talk about it. We are seeing more readmissions. It's kind of a mixed bag, I guess. The programs that have been following patients for 30 days post-discharge for several years are seeing readmissions, but they're also paying attention for those first 30 days and trying to bring them back in under that 30-day window. So they're not going back to the ED, they're not going back to acute, they're coming back into the swing bed program. So that's one set of factors to be considered. I think we're going to see more readmissions. In fact, I know we're seeing more readmissions with post-COVID patients. I don't know that it has been quantified yet. I haven't seen anybody quantify it yet, including the federal government.
Yeah, I definitely know that in talking with hospitals across the state that they're really starting to see an increase in the complexity of patients and creeping up that overall length of stay too. So
yeah, so the point of all of this is there's no one way to do this. There's not a right, there's not a wrong. You don't have to pay attention to it. You can pay a lot of attention to it. You can decide you can only deal with 10% of those with post-COVID issues, depending on your specialist. This is an individualized discussion for your hospital. There's nothing saying you have to do it. There's nothing saying you can't do it at this point. The question is, what's going on in your neighborhood? What kinds of needs are cropping up where we're going to have to take care of some of these patients? And when is it appropriate for them to stay in the skilled setting, if they're living in a long-term care facility already, because that is their home, versus needing the more complicated care that we can provide because you are a hospital-based service. So this is for you to mull over, start talking with your area nursing homes, so you start figuring out, is this a problem of 9 people right now, or is this a problem of 29 people right now? And that may make some differences in your discussion. And I'm going to do one more slide, Becky, and then we can do questions. Plus, I have something else to add.
Sure.
I have added this to the end of this, so this has nothing to do with COVID, particularly But just as we've seen the telehealth take off, we're beginning to see paramedicine models take off across the country. It's really dependent on who owns the paramedics and the ambulance services in your areas. All these here are listed are rural systems that are doing paramedicine. They're all doing it for something different. One of my favorite, for instance, is the Virginia one, where they have set up a program with paramedics and a social worker doing home visits for high utilizers. In other words, those guys that come back to your ED all the time, and they have reduced their call volume by 60% with this program. Sligo County, which is just about 30 miles down the road from me, they actually are doing home safety inspections. They do vital signs. They can administer vaccines. A lot of them are set up to serve as a stopgap. So if you discharge on a Friday and home health isn't going to even come into eval until Monday or Tuesday, making sure somebody's checking on them. I think it's something for you to watch. Again, all these models are completely different right now, and your access to your paramedics may be different. I have put in here the website for you to check that we at least give you some basics. But I do think that may be something with telemedicine that we're seeing evolve out of COVID that will probably end up being permanent. So with that, one other thing, I don't forget, somebody asked about cardiac rehab, and Becky knows because she asked me about every 7 minutes. I'm exaggerating slightly. But I have sent this to CMS, and CMS is not answering. And it's not just, they're not answering me, they're not answering anybody right now. There are plenty of queries going out. I think they're in the middle of so many changes at this point, they're probably holding on the question. So let me give you sort of a basic on cardiac rehab. Cardiac rehab has never been allowed in skilled nursing, ever. It is an outpatient service normally. And one of the reasons that those of you that are doing cardiac rehab, you know there has to be a physician there, and they have to be monitoring. And then there's the uptick of a potential, for a heart attack and other effects during a rehab process. So I can only kind of go back to the basics, which cardiac rehab in a skilled bed has not been a service that Medicare has approved in the past. And until I hear otherwise from them, I'm going to suggest that it needs to stay in your outpatient setting with a cardiologist or whoever you have monitoring the program. Okay, on that one, Becky, because I don't know any other way. That's the safer version of it until I hear something specific.
Mm-hmm.
We do have questions, comments?
We do have a couple comments in chat. Crystal has shared that we've seen an increase in readmissions specifically with COVID. This is on their inpatient side, and there seems to be an increase in patients requiring at day 10 to 12 of illness after initial treatment and stabilization. And then Sonia
10 to 12
also
days after. Okay.
Mm-hmm.
Okay.
And then Sonia shared that in regards to the paramedicine program, we do have an area, Crawfordsville, Indiana has a program, a paramedicine program where they're doing a lot of the activities that you described. So beginning to spread in Indiana too. I believe they've had that in place now a couple of years or so. So wanted to share that.
Well, that's cool because now you have somebody inside your state, which means they have to understand the state rules that are impacted by this, because every state has different rules for the contact. I'm just saying it may be, and again, as we look at long haulers and we look at our aging population and chronic illness, it may be something that ends up being very fruitful for keeping what I'm going to call unnecessary visits to the ED or hospitalizations, because that's what Medicare has been trying to reduce. And it's interesting, Crystal, thank you for sharing that. It makes a lot of sense. And my comment on that, if you're seeing them 10 to 12 days later, that's just going to reinforce to me to suggest one more time that when people are discharging from your swing bed programs, you need to follow them for 30 days because they can come back into your swing bed program, again, without having to go through ED, assuming it's still related to the same issue. But that may be something, again, where you can readmit them without unnecessary, quote, unnecessary ED visits and so forth. So, Crystal, the second piece would be interesting now that you are seeing that, what patterns develop out of that? Like if you intervene, call them, get them back into your swing bed program, is that making a difference? What types of patients you're seeing? I think we all have some individual work to do because there's not going to be one mass answer that I can see yet. And I think we'll get it into categories. We're just on the front end of this.
Another comment that was shared with me via email is that how do you balance adding different types of patients and balancing adding staff to bringing on like a new group of patients? And I know in a couple areas of the state, they've been reaching out to some of the referring facilities, and now there may be groups of patients that they'll be receiving. So any guidance around balancing the number of patients that you bring on and adding staff?
There's probably multiple subsets into that that's going to be, within each of your regions. I've got programs now. I have a nursing home that for the last 11 months has been down 21 CNAs. So it wasn't even a matter of them adding anybody to their population. They were trying to care for the long-term care residents they already had, with a severity and reduction of staff. So I would be looking internally. I don't think this can be answered externally as to where you are with your staffing numbers. I do know that I am seeing some CNOs start looking at the combination of acute patients and swing bed patients. I don't know if you're running on a, 6 patient, I'll just say 6 right now because there's varieties of answers in that. And they're finding that their swing bed patients are sick enough that they're not distinguishing substantially differences between the swing bed stay and the acute stay as far as the nursing, need for nursing. So I think that's a piece that has to be evolved internally. And then, as I said, we're going into flu season. I think the other part that we have to balance is how many beds have you traditionally needed in the past when we go into the winter months, for acute patients, paying attention to that. And you'd want to staff appropriately for acute first, that is your licensure, and then figure out the swing beds patients that you can take. It is a balancing act that I'm not seeing anybody figure out the perfect formula for. It is causing multiple headaches. And I guess it's going to be that way for a while, though I hear the nursing schools are trying to pick up numbers to discharge more nurses into the world. But any of you that have been in the industry for a while, I'm glad that they're doing that. But new nurses also have a learning curve. So we've got some complications there too. I think just to try and answer your question more directly when there is not a direct answer is, you've really got to look at traditionally the types of acute patients you've had, how many you've had in the winter months, and then decide how many swing bed patients. So if a nurse could handle, I'll say 5 patients in acute, can they handle 7 if a couple of those are post-acute? So those are internal discussions. And I don't know of one formula that works for any hospital in this country. Just, people can do numbers, and I won't pick on financial people, but they're very good at looking at Excel spreadsheets and saying, here's our staffing costs and here's our revenue. But then we get into the reality of what's going on the floor. So that's why I'm going to defer to those of you who are involved in nursing to figure out if there's a formula that, can help you if there's more of a swing bed mix in there and what that means.
Thank you. Kerry, a question that I've received myself over the last few weeks is around the waivers ending. And so ongoing foresight, if you would like to share.
Yep, they re-signed the waivers. So they are in place till the middle of January. I don't remember the exact date right now, so I'm not going to quote it, but the middle of January, they're still in place. And And remember, they still have to give us 60 days notice if they're not going to re-sign, which means if it's middle of January, that means the middle of November, they should be giving us a heads up if they don't plan to re-sign it. I haven't heard anything. That doesn't mean anything at this point, but I would presume by middle of November to end of November, we're going to hear rumblings that they think all of them aren't going to be re-signed, or however they're going to divvy this up. There is legislation, and I hate to say this, but I don't see much of this type of legislation getting through Congress these days. But there is legislation to do away with the required 3-day stay. It's been there almost a year now in Congress, in committee somewhere. So I don't know that could also get pushed through at some point as another alternative. But for now, we can use any of the waivers you might be using, whether that's acute, any of the skill level waivers through the middle of January.
Okay. We have about a minute left. So any other questions? And again, feel free to unmute your line in the participant list. You can click the microphone button there, or if you hover at the bottom of your screen, the mute button should pop up, or chat in any additional questions that you have.
And I've just opened chat, and I did see Crystal writing again that they're looking at admitting back into the swing bed, but they've got to get everybody's buy-in. And that is correct. This isn't done on the spur of a moment. You've got to have a plan in place and what that means if you're readmitting people.
Thanks, Crystal, for sharing. We appreciate that.
Mm-hmm.
Not seeing any other questions for today, so keep those coming in, and stay safe. Thank you so much, Kerry, for sharing the information. COVID definitely doesn't seem to be going away and having some after effects, so the information you shared today was very helpful. Always glad to help anyone with their programs, and want you all to stay safe, and just want to thank you all so much for everything that you do every day. So have a good day, everyone. Bye-bye.